Hello everyone, I'm Dr. Sarita Jain, an obstetrician, gynecologist, and infertility specialist. In today's video, I'll be speaking on guidelines on gestational diabetes. So, first of all, what is gestational diabetes? It is defined as glucose intolerance first recognized during pregnancy. GDM is mainly classified into two categories. First is A1 GDM, which is controlled by the diet only and no medications are required. Second is A2 GDM. It requires medication for the glycemic control. Now, what are the symptoms of GDM? GDM usually doesn't cause any symptoms, but some people experience frequent urination, nausea, thirst, and tiredness. There are mainly two factors responsible for the development of GDM. First is pancreatic beta cell dysfunction or delayed response to glycemic level. Second is insulin resistance to the placental hormones. Mainly human placental lactogen is responsible for the insulin resistance. Other hormones contributing to GDM include growth hormone, prolactin, corticotropin releasing hormone, and progesterone. There are certain risk factors also for the developing GDM. These are increased body weight when BMI is more than 25, decreased physical activity, any first degree relative with diabetes mellitus, history of GDM in previous pregnancy or newborn with the macrosomia in previous pregnancies, metabolic comorbidities like hypertension, low HDL cholesterol, high triglycerides, history of PCOS, HbA1c more than 5.7%, abnormal oral glucose tolerance tests, and markers of insulin resistance like acanthosis nigricans. And if there is past history of cardiovascular disease. So these are certain risk factors which are when present, there will be high chances for the development of GDM. GDM affects about 2 to 10% of the pregnancies in the United States. Women with GDM have a 35 to 60% increased risk of developing diabetes mellitus within 10 to 20 years after the pregnancy. Now, what are the guidelines on the gestational diabetes screening? ACOG recommendation, according to this, it does not recommend routine screening for GDM before 24 week of the gestation. It supports a two-step screening approach between the 24 to 28 week of the gestation. First is the initial screening, which includes 1 hour venous glucose measurement after a 50 gram oral glucose solution. And second is confirmatory test. If initial test is positive, then a 3-hour OGTT is done with 100 gram glucose solution, and diagnosis of GDM is based on having minimum 2 abnormal values on 3-hour OGTT, and there are insufficient evidence to diagnose GDM based only one abnormal value. Patient with one elevated value may require additional surveillance. ACOG suggests using Carpenter and Costin criteria instead of NDDG criteria for the screening. NDDG criteria have higher threshold which may miss patients who would benefit from a GDM diagnosis. According to Carpenter and Costin criteria, fasting blood sugar should be less than 95 mg per deciliter, 1 hour blood sugar should be less than 180 mg per deciliter, 2 hour blood sugar should be less than 155 mg per deciliter, and 3 hour blood sugar should be less than 140 mg per deciliter. We can consider early screening for gestational diabetes in patients who are overweight with the BMI of 25 and one or more of these conditions are present, like physical inactivity, family history of diabetes is there, if there is previous pregnancy history of GDM or macrosomia is there, if there is hypertension, if HDL cholesterol is low, if fasting triglyceride level is high, if there is polycystic ovary syndrome or any condition associated with insulin resistance is present, like acanthosis nigricans or morbid obesity. If HbA1c level is more than 5.7% or impaired glucose tolerance or impaired fasting glucose is there, then we can consider for early screening for GDM. If HbA1c is more than 6.5%, then the diagnosis of pregestational diabetes is met and GCT or GTT is not needed in this condition. Other condition in which we can consider early screening are if there is a history of cardiovascular disease, if there is history of HIV, or if age more than 35 years or older. Now, screening for diabetes and pre-diabetes in postpartum period should be done to diagnose diabetes and pre-diabetes between 4 and 12 weeks postpartum. Now, what are the target blood glucose level? According to ACOG, to reduce the risk of the macrosomia, following glucose target levels for pregnant women are considered. Fasting or preprandial blood glucose level should be less than 95 mg per deciliter. 1 RPP should be less than 140 mg per deciliter, and 2 RPP should be less than 120 mg per deciliter. And for the diet plan, they can consult to the dietitian or nutritional team if available, and emphasis should be on taking complex carbohydrate, and they should be recommended to take 3 meals and 2 snacks to stabilize the glucose levels. For exercise recommendation, aim should be at least 30 minutes of the moderate intensity aerobic exercises at least 5 days a week or 150 minutes per week, and walking for 10 to 15 minutes after each meal can help manage the blood sugar levels. And blood sugar levels should be monitored after starting dietary changes to ensure the control. Ideal distribution of the calories between the carbohydrate, fat and protein may vary, and personalized guidance is essential for this. Now, the pharmacologic treatment for the GDM. If glycemic control is not achieved with the non-pharmacologic method, then insulin is the drug of choice, and starting dose is 0.7 to 1 unit per kilogram daily and should be given in divided doses. Ideally, total dose is divided into the two half. One half as basal insulin is given at the bedtime, and other half divided between the 3 meals as rapid acting or regular insulin before meals. Doses should be individualized based on the patient's glycemic pattern. Now, the type of insulin. There are 2 types of insulin mainly. One is short acting insulin, that is Lispro and Aspart, and these are preferred due to their rapid onset and lower risk of the hypoglycemia. Another is long acting insulin, and it is Determir. It is approved for the use in pregnancy and causes less nocturnal hypoglycemia. Now, if insulin cannot be given because of some reason, then metformin is the next option, but it should be given cautiously because it crosses the placenta. Starting dose for it is 500 milligram at bedtime, and then it is increased gradually up to 2500 to 3000 milligram per day. Before giving metformin, creatinine level should be checked, and patient should be monitored carefully because it is associated with the preterm birth, and also it has some adverse effect like abdominal pain and diarrhea, so it should be taken with the meals. Another drug is gleburide, but it is not recommended due to worse outcomes such as macrosomia and birth injuries, so it's better to avoid this medicine during the pregnancy. Now, how to do fetal monitoring for these patients? If it is poorly controlled GDM, that is A2 GDM without comorbidities, then monitoring can be started at 32 weeks, and if it is associated with any complication, then monitoring can be started even early. If it is well controlled and managed by the diet only, that is A1 GDM, then there is no consensus on fetal assessment because there is low risk of the stillbirth in these patients, and if monitoring is started, if it is started later. And there should always be monitoring should be done for the amniotic fluid to rule out the polyhydramnios. Now, when to deliver these patients? If it is controlled on the diet, that is A1 GDM, then delivery can be done between 39 weeks and 40 weeks plus 6 days. If it is well controlled on the medication, that is A2 GDM, then delivery can be considered between 39 weeks and 39 weeks plus 6 days. If it is poorly controlled, that is A2 GDM, then timing should be individualized. But exact timing lacks clear data. Now, delivery may be considered between 37 weeks and 38 weeks plus 6 days for the specific reason. Delivery may be considered between 34 weeks and 36 weeks plus 6 days if in hospital glycemic control fails or fetal testing shows abnormalities. And if fetal weight is more than 4.5 kg, then elective cesarean section can be taken. Now, how to do postpartum monitoring for these patients? It is recommended to do monitoring of these patients at 4 to 12 weeks by the 75-gram oral glucose tolerance test to rule out the development of type 2 diabetes and to rule out the impaired fasting glucose. Both ADA and ACOG recommend repeating these testing every 1 to 3 years for women who had GDM and normal postpartum screening results. Now, what can be the complication in these patients? We can divide the complication into fetal complication and maternal complication. Fetal complications are macrosomia, neonatal hypoglycemia, polycythemia, shoulder dystocia, hyperbilirubinemia, neonatal respiratory distress syndrome, increased perinatal mortality, hypoglycemia. And maternal complications are hypertension, preeclampsia, increased risk of developing diabetes mellitus, and increased risk of the cesarean delivery. So this was all about gestational diabetes mellitus. If you found this information useful, please like my channel and share the video and subscribe my channel. Thank you.